Hello, and welcome to the fourth session in the Alliance's 2020 Signature Series Summit on Disruptors and Transformers. I am Catherine Martucci, Director of Policy and Programs for the Alliance for Health Policy. For listeners who are new to the Alliance, welcome. We are a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. And the goal of this multi-part virtual summit is to explore the short and long-term impacts of the ongoing COVID-19 pandemic and its potential to significantly transform our healthcare system. We want you all to be active participants in this discussion today, so please get your questions ready. You should see a form on the right side of your web browser that is labeled Submit a Question. You can send in as many questions as you would like at any time, and we will collect these and address them during the broadcast. You can also find all the materials that accompany this session on your Summit interface and on our website, allhealthpolicy.org. And finally, if you have any technical issues during the duration of the event, please click on Troubleshooting Tips/Technical Support in the bottom left-hand corner of your screen. We also encourage you to join us on social media by using the hashtag AHPSummit20. You can use that hashtag to engage with us after sessions end as we continue the conversation online. And please tune in again this afternoon at 2 p.m. Eastern for the final session of this series, a recorded conversation with Chris Austin, who is the director of the National Center for Advancing Translational Sciences. Dr. Austin sat down with us recently to discuss a collaborative research approach that he and his colleagues at the NIH are working on to advance treatments for COVID-19, and it'll be a great follow-up conversation to this panel discussion today. So now it is my pleasure to introduce our guest moderator, Rob Saunders. He is the Director of Payment and Delivery Reform at the Duke Margolis Center for Health Policy. Prior to joining Duke Margolis, he served as special advisor to the president of the National Quality Forum, where he directed special projects on topics including data, payment reform, systems engineering, and the future of healthcare quality measurement. And he's also held positions on Capitol Hill and with the National Academies of Medicine. So we are very grateful that he is here today to lead this discussion. Rob, thank you, and please take it away.
Thanks, Catherine. So as Catherine said, I'm Rob Saunders. I'm with the Margolis Center for Health Policy at Duke University, and I'm really pleased to be here today to moderate this panel to dive into some of the data issues and technology issues that are affecting us as we're trying to become more resilient during the COVID-19 outbreak. I'm pleased to introduce our distinguished panelists. They've got long and distinguished careers, so I'm going to give a pretty short introduction, and you'll find their full bios in the handout section of your Summit interface. First, we have Dr. Kenneth Mandel, who is the director of the Computational Health Informatics Program at Boston Children's Hospital and the Donald A. B. Lindbergh Professor of Pediatrics and Biomedical Informatics at Harvard Medical School. Among his many accomplishments, Ken received the Presidential Early Career Award for scientists and engineers for pioneering real-time systems for biosurveillance, so tracking infections and detecting outbreaks using diverse data. And Ken's going to help us think through a lot of the issues that hospitals and healthcare delivery systems are thinking about in addition to other settings. Next, I'm pleased to introduce Ravi Chawla, who is the Vice President of Informatics at Independence Blue Cross, where he leads work in a number of cutting-edge initiatives, including advanced and predictive analytics, which had a particular role in understanding risk during the COVID-19 epidemic, as well as thinking about how to leverage the data they've got to help improve patient care quality. Next, we have KP Yapola, who is the CEO and founder of Access.Mobile International. KP is an expert in national scale health program implementation, technology innovation, and the intersection of health and technology policy. And then finally, I'm pleased to introduce Devin McGraw. Devin is the Chief Regulatory Officer for Citizen, which is a consumer health technology startup. Previously, she was in a variety of federal positions, really overseeing a lot of the work in HIPAA, or the privacy aspects of health data policy, including at the Deputy Director of Health Information Privacy at the HHS Office for Civil Rights, as well as the Chief Privacy Officer of the Office of the National Coordinator for Health IT. So let's get things going, and I'll start off by asking each of our panelists an opening question, and then we'll dive into discussion. We hope this is an interactive session, so we'll start off with a few questions for the panelists that I have, but really want to hear from you and what you want to hear about. So please do use the chat function that Catherine mentioned, and I'll monitor that and bring those into the discussion with the panelists. So let's start with Ken. And really, I'd like to start with a level set. So data reporting for COVID-19, as with any public health data, is relatively complex in that it involves a number of healthcare providers who are the ones doing a lot of the frontline testing for COVID. Your local public health departments, it involves your payers, it involves state health departments, who are often the folks that keep a lot of the vital statistics and public health infrastructure, as well as our federal agencies such as CDC. So Ken, I wonder if you could kick us off by just giving us that level set of how does data reporting work now, and what are some of the challenges we're seeing?
Thank you, Robert. That's exactly the right question to kick us off. The answer is that acquisition of data for public health intelligence is patchwork right now, somewhat of a by hook or crook approach. With focus, funding, and planning, I think we can do better. I'll describe two major systems that we have in place now for collecting data from hospitals and providers. For the first, there are specific requirements from the administration for hospitals to report on a daily basis information about hospital beds, testing, results. These data pertain to operations and logistics and include information on hospital capacity, testing, and to a limited extent on the epidemiology of COVID-19. They were being collected by CDC's National Healthcare Safety Surveillance Network, now by a private vendor. The second is the National Syndromic Surveillance Program, which collects what are called chief complaints. These are the reasons for visits written out in short strings of text from thousands of emergency departments across the country. The first system I mentioned operates in a traditional public health mode of reporting. A human being is at the hospital, puts together a spreadsheet or something similar, and securely sends it to a central authority. Public health has for decades relied on physicians and hospitals to report conditions, for example, an unusual unexplained illness in the ICU or a routine case of West Nile virus. The second system was inspired by public health informatics research that several colleagues and I were engaged in around September 11th. Before 9/11, I had a computerized system collecting emergency department data, performing analyses, looking for trends of disease over time, spatial clusters of disease that could indicate a potential bioterrorist attack. That was our focus then. Right after 9/11, I extended this system to work across ERs in the Commonwealth of Massachusetts, and the CDC created a federal system based on these approaches. This type of system is called an active surveillance system, which contrasts where when public health is in a passive mode, waiting for reports to arrive. With active surveillance, public health is constantly receiving big data and able to apply data science analytics to it. Together, these two systems provide the federal government with important but limited public health intelligence. I'll highlight a few considerations. First of all, we should be advancing away from manual reporting, which does not scale well, towards active surveillance systems that are fully automated. Secondly, the majority of public health response is local, so we need systems that empower state and local health authorities with rich and actionable data, while also affording a comprehensive and bird's eye view for the Centers of Disease Control and Prevention, which is where authoritative expertise in national scale public health response resides. Thirdly, when large amounts of data are shared with any party, including governments, appropriate guardrails and protections for the security of those data and the privacy and autonomy of our citizens must be in place. I'll forward point to Devin McGraw's upcoming remarks on this topic. Fourthly, and very importantly, public health is in a privileged position to take full advantage of a massive federal investment in electronic health record infrastructure. In fact, under the HITECH Act, $48 billion were invested to promote adoption of these technologies. This was accompanied by likely close to $1 trillion of private investment in purchasing and installing these systems. The problem is that these systems are made of older software, electronic health records, which does not allow nimble use of those data. Over the past 11 years, my group, the Computational Health Informatics Program at Boston Children's Hospital, developed what are called application programming interfaces, which enable us to connect apps to electronic data and export data in standardized and interoperable formats. I do not do very much lobbying, but I managed to get a sentence into the 21st Century Cures Act requiring these APIs in all certified health IT. Both HHS's Office of the National Coordinator of Health Information Technology and CMS have issued final rules this year that will ensure there is no information blocking and the data can be exchanged using modern interoperable software paradigms. These technologies, laws, and regulations have emerged over 2 administrations in an inspiring show of bipartisan collaboration across 2 branches of government. This means we can go well beyond chief complaints alone, which are small strings of text entered by ER triage nurses or registration clerks as our data source. In fact, we can access and exchange rich information using identifiers only when necessary for justified public health response on nearly all Americans. We need to know now not only how many patients are tested and how full hospitals are, we also need to know which therapies are working. What is the spectrum of clinical manifestations of COVID-19? How many patients are requiring dialysis? How many have rising signs of kidney failure and will require dialysis? What are the laboratory profiles of children who have multisystem inflammatory syndrome? The value of current systems is not to be minimized, but they do not yet get us where we need to be. Thank you.
Thanks, Ken. And that was a really helpful overview, as you say, of a pretty complex topic because there's so many actors involved. We've got a lot of new technology, we've got a lot of legacy technology, and we're all trying to put it together. One group that's also involved in a lot of healthcare data and a lot of healthcare decisions are our private health insurers. And so I want to turn things over to Ravi. Ravi, I know you've been thinking about for some time how to use data to help make decisions for the particular private payer you work for. I wonder if you could share a little bit more about what data assets you have and also how those are being leveraged.
Absolutely. Thank you. As part of the response to COVID, I will say that insurance companies definitely, we are at the end of the game, if you will, when it comes down to the data. But at the same time, some of the investments in health information exchange and the connectivities that the payers have made to those health information exchanges have helped us in at least collecting some of that data and analyzing that data around response that we have to do for our members and our customers. So we as a company, we are linked with a health exchange data set, and we are also getting authorizations. We get lab data, we get pharmacy data on a regular basis. So this, as soon as the pandemic hit, we were able to use some of those data sets and data levers to make policy changes. So as a payer, one of the initial things that we did as a company was, do we want to, we removed cost share for our members. We removed authorizations for our members and our customers, primarily because of the pandemic. We were able to make these policy changes as we were seeing data coming into our system. We expanded some of our telehealth services, even beyond PCPs. We expanded it to specialists, we expanded it to behavioral health specialists. And then we were also able to take, all the data assets that we have as a company in order to build predictive models so that we could do the outreach to some of our vulnerable populations. As part of the COVID, we are sitting with tons of data, from a longitudinal perspective. The depth of data primarily resides with the providers. And, we have, to what Ken was saying earlier, we have invested heavily in what we call big data and data lakes, where we are bringing in, EMR data, the electronic health records, into our systems, as part of either our value-based contracts with our providers, so that we not only get the longitudinal aspect of the data, but also the depth of the data. So, we were able to build models around likelihood of hospitalization. We were able to build models around which of our Medicare members or commercial members are at risk, so that we can do certain kind of outreach to those members. At the same time, we also we worked with our regional home care providers in order to come up with a database so that we could figure out the capability and the capacity associated with some of these home care providers. So a lot of the policy decisions that we did as a company, they were all data driven, they were all analytics driven. At the same time, from a corporate perspective and from a payer perspective, we were able to build dashboards that was rolled out across our entire business spectrum, so that people could look at where we were as a payer at any given time with regard to either the number of cases for COVID, and we are still following that on a day-to-day basis. We get lab data on a daily basis. We get pharmacy data on a daily basis. Initially, I do, when the lab testing areas were not commercial, they were more limited to the state centers. We did not get some of that data, but because of our EMR data exchanges that we have our providers with, we were getting lab results from the hospitals. We were getting it from our, the Quests and the LabCorps of the world, so that at least we could have some kind of informed decision making, as a pair. So, I'll stop at that. I'll come back and talk about other components of it, but, happy to take any questions around that.
Thanks, Ravi. And another issue really that's come up with COVID has been the spotlight on health equity, given the massive differences we've seen in both the prevalence and outcomes based on race and ethnicity. And I want to turn this over to KP. What challenges are we facing in using some of the data that we've been discussing with Ken and Ravi to be able to drive down those disparities, and what do we need to do more?
Great, thanks, Rob. And I'm just going to build on the comments of the other colleagues. And for me, health equity is really at the center of this conversation with COVID nationally, and we know the facts. So just to talk about the situation, communities of color, indigenous populations, underserved populations are bearing the brunt of COVID morbidity and mortality. And so we ask ourselves why. Our conversation has started on this years ago, frankly, around social determinants of health, racial and social injustice, and other factors that drive these differential outcomes. And so what we're seeing those variables play out in the distributed burden of COVID. And so issue one is I like to frame issues of social determinants of health and those data sources. So groups have already started doing that work pre-COVID, understanding that the drivers of morbidity and mortality oftentimes are associated with non-clinical risk factors. So, but where we are in terms of collecting those data sources of SDOH and integrating them into our analysis, it's still a nascent space. So I know Ravi's mentioned like some groups are further along than others, but that does create a certain challenge trying to get ahead of COVID now when those data sources are not in play. Also, something relevant when we think about COVID is that, traditional thinking would just say, if you look at data, Blacks and Latinx populations have a higher burden of comorbidities, and data shows that those comorbidities make it more likely or make you more vulnerable to catch COVID and to die of COVID. But actually, that's not the complete story around the data. If we look at it, things such as one's ability to work from home or not work from home probably may be one of the biggest risk factors or drivers of whether or not someone gets COVID. And so even in our ability to, one, understand the situation, but also to be more predictive around who's at risk, requires us to bring in data sources that may not be traditionally used in analyzing this type of issue. For example, what type of jobs do people have? Are we looking at labor statistics? Are we looking at income level? Are we looking at where people live? Those are some of the gaps, right? So it's not as much as just to say, oh, because Black and brown people have these higher comorbidities, that's the reason, right? Like if you don't have the choice to work from home, every day you go out and work, you're exposing yourself, and common sense alone would tell you that person's at more risk. Lastly, there's a few other things, but I know there's going to be probably a lot of questions here, but on testing, when we think about incomplete data. When people go to get a test, that's an opportunity to capture data. And so the question is, who's going to get those tests and what are we collecting? And we know that there have also been some gaps at point of care, point of service delivery around what's being collected when people are getting tested. So there are other opportunities in the chain. Lastly, when it comes to issues of lack of trust in institutions, underserved populations, Black and Brown populations have had a very complicated and oftentimes poor experience with service delivery in the healthcare sector. Building on that, those populations may be less inclined to share data. So we have to consider our intentionality around how we're engaging those populations and not just assuming that data will be shared, because ultimately people will share data if they feel like they're going to get a benefit and there's trust. So I'll hold there for now, but I'm curious to hear others' thoughts and from our participants.
Thanks, KP. And then the final opening question, I'm going to turn to Devin. So Devin, COVID's been really an accelerator for a number of technological transformations in healthcare. It's been said that we've moved maybe a decade in telehealth in the last, 4 months. But we haven't seen the types of improvements in a lot of the data reporting and use that we hoped we'd see. We know that this type of technology doesn't exist in a vacuum, and there's a number of privacy advocates that have been rightly concerned about how the data are being collected, shared, used. Can you talk a little bit about some of those privacy concerns and how effectively they're being addressed now?
Sure, I know, I'd be happy to. I think this whole experience around COVID is almost like the perfect storm of privacy challenges and health data sharing. I mean, we've always had sort of a number of health privacy issues that have confronted us, particularly moving into electronic health records, personal health record, the rise of consumerism in terms of people collecting data outside of HIPAA. Like, those have always been challenges, but it almost feels to me like COVID is like, wow, all of these things are clashing together. And I think that there's a reason for that. Ken talked about sort of traditional public health surveillance that has gone on for decades. And our laws have always allowed for data to be shared with public health authorities for public health purposes. HIPAA allows it. International law allows it. This also includes contractors that might be working for public health departments on their behalf. So we've always had sort of disease surveillance reporting into public health. And yet with COVID-19, the idea that we were trying to step this up and do this suddenly was very alarming to people, as though it had never happened before, ever. And I think that there's a number of reasons why the concerns are so heightened this time around. One is that we're in a sort of post 9/11, post Snowden, post Cambridge Analytica era, right, where there is deep distrust around data sharing, including and maybe particularly with government. And I think KP's remarks were spot on in terms of trust in data sharing by marginalized communities and communities of color. Anytime data is shared for good, you increase the potential that it can also be shared in negative ways, like ways to discriminate against people. And if you've been harmed by a use of your data in the past, you're going to be doubly concerned about sharing it, even if sharing would be to your benefit or to the benefit of your community. And we don't have laws necessarily that prevent some of those bad things from happening. We're just sort of expecting that this data sharing must happen, and it will happen without having to take care of any of the negative consequences that can occur. I think the other thing that's a bit unique about this particular pandemic as compared to other epidemics and sort of health crises that we've had to deal with that have data needs is the entry of big tech into the space. And, frankly, I think there's a lot that technology companies can bring to the table in terms of their capabilities around data analytics, around use of smartphones to potentially assist in contact tracing. I think we all know about the partnership between Apple and Google, which is very unusual. They wrote themselves a set of behavioral norms and said, here's how we're going to share this data, and we are not going to share it for any other purpose. We're going to be very regimented in that regard. These are commitments, frankly, that the federal government through the Federal Trade Commission could enforce against these companies, and yet people are not rushing to use them. and some of that has to do with a lack of familiarity on the part of public health departments in using some of these bigger technology solutions. But I think a lot of it also has to do with just this innate distrust that we have in how tech companies handle our data, which is creating some obstacles to being able to leverage some of those solutions. So the gaps that we have in law, this is probably a fairly sophisticated audience, but in case there's somebody out there who doesn't know that HIPAA does not cover all health data, it actually has fairly limited coverage. And there are lots of gaps in terms of privacy protections for all of the potential recipients of this data, including employers. Frankly, public health departments are not covered by HIPAA. They're typically covered by state law if they're within a state, or the CDC has a federal law that all federal agencies have to comply with called the Privacy Act. But there's just a lot of gaps and a lot of uncertainty, I think, for members of the public in terms of what's going to happen to this data once it's collected, and what sort of protections can I rely on?
Great. Thanks, Devin. And I see that we've gotten a number of questions through the chat, and thanks, folks, for sending those along. I think one question that I'm going to maybe start with, and it raises sort of a broader issue. So someone asked, is there a wide variation in the lag and both the collection of data and the reporting and receipt of that information to others? I'm assuming they're probably referring to, say, the state public health departments or the CDC or HHS. And this really raises sort of a broader question that's been in the news lately, thinking about the CDC and some of the changes in reporting to the CDC and to other groups in HHS. So, with that question about lag, throw it open to the group, what types of lags are we seeing in the type of reporting? How does that differ? And then what can we do about it to be forward-looking? Ken, I think maybe you wanted to jump in and talk about some of the CDC data modernization and some of the CARES Act funding for state data systems. Maybe that'd be a good way to start this discussion.
Yeah, so traditionally, the reporting model of public health data does tend to lead to lags. And yet, with the modernization that the federal government has invested in around a health information technology infrastructure, which is largely provider system based, but also has interesting sockets for patients to plug in as well, does not yet have good sockets for public health to plug in. However, those could be readily created on the basis of the open architectures that are being used. And the data could become relatively real time out of healthcare systems to public health. There's no reason that those data can't be shared in real time or in near real time. There's been substantial investment in public health modernization, and the CARES Act also has appropriations to states to bolster their public health infrastructure and testing infrastructure. There's an opportunity to try to not end up with 50 incompatible systems across the states. There's an opportunity to use the newly regulated technologies that seem very wonky to get into, and yet are precisely the technology that, for example, Apple used to connect its health app to about 500 health systems, so that all patients at those systems in real time can get a copy of their data on an iPhone and expose it with their permissioning to apps that help patients use those data to improve their health. So Apple was able to use this technology at scale. And this was before the 21st Century Cures regulations went into place. Public health has traditionally not been at the table when it comes to designing these systems. And yet, because these rules were just passed, and because the time frame for the full technology to be deployed is between now and 2022, we have a moment to actually get together and prospectively design the system that we want to see at the end of this. And 2022, while it seems a long way away, is just around the corner when it comes to technology development and deployment at the scale that we're talking about.
Great. Thanks, Ken. And KP, I wonder if you want to jump in here as well. You know, part of the collection part is really thinking about informed consent for that data collection and for the use. And as you flagged in your opening remarks, part of that depends on the level of trust, which may not exist, especially among some communities of color. I'm just kind of curious on your reflections here.
Yeah, so there's multiple sides to this issue. So when we look at health equity issues and racial injustice in the health system, it's about the delivery of care. So it's what's happening on the supply side. It's about people's experience, right? And so what you have for populations that have experienced that historical injustice is that when we're in this type of health crisis, all they're thinking about is like, am I safe? Like it's for many populations, they would assume if I go to the doctor, I'll be safe. There are conversations even amongst African-American leading docs in the country where certain African-American populations would prefer to stay at home than go to the ER with COVID, right? And some of them may prefer to die at home, right? So that tells you the level of the depth of lack of trust. And so then obviously if that's there, we can't get to the data, right? How can we get to the data when that's the dynamic in the interaction of the system? So, you know, our experience of best practice and part of what this means from a data perspective is we have to go to community organizations. So most of COVID response for the populations that we're talking about now around health equity, the only way to succeed is to work through community institutions, churches, community organizations. And in many ways, those institutions are not just a channel to build trust and get populations to engage the system, but it's counterintuitive, but that's where that's the system that's most likely to get the data you need, right? So even if we're talking about a small sample of data set, when someone goes in for testing, I want 5 indicators, right, that I want to collect. How someone's interacting with testing, where that testing site is. For example, is that testing site at a church in a community? One, that's going to help drive more engagement, and then that's going to drive more likelihood that people might be willing to share data, because to Devin's point earlier, it's like, you know, all the different elements of mistrust, so it's not just one thing, and we have to crack through. So while it may seem a tangential topic, if we can't bridge those issues, that's going to create dark spaces in our data because people won't engage. And even when we think about implicit bias within tech systems, you know, if a system is using data to learn and there are dark spaces in that data that are missing huge pockets of populations, that whole system is going to bias technologically. So those are some of the things that are sometimes maybe not as straightforward or you know, they're a bit nuanced, but they matter, you know.
Absolutely. And I'm going to jump to the next question because it ties in with this one in a number of ways, but it also takes it to the next level in a variety of sort of technical levels. So some of the questions we've been getting in are, you know, are there ways that we should be thinking about improving the integrity of the data by saying reconciling some of the public reporting with claims data? You know, whether there would be potentials to introduce some sort of uniform reporting protocol or a uniform user interface. And really, I think these questions are getting at some of the broader technical issues that are keeping the data from being as useful as it could be for COVID reporting and use and frankly, just overall resilience. Devin, I wanted to kick things off with you. I know you've been doing a lot of thinking, especially given your ONC purge, around EHRs, health information exchanges, and the early focus on data collection versus use versus sharing. So I wondered if you have reflections on this question.
Yeah, I mean, you know, we're not going to be the country that says, here's the one interface that you use, and here's the one system that you throw all your data into, because that's just not how we operate. And I'm not sure that that's necessarily the right approach, even if we were inclined to do that. You know, but having said all of that, we do need to get this data into public health, into the hands of entities who can make responsible decisions about it, and we need to get it done quickly. I thought, Ken, you painted a pretty optimistic picture around just how far we've come in terms of the technology adoption and how we're sort of on the precipice of being able to share the data, only the data elements we need, but all of the data elements we need with public health digitally, quickly, and that 2022 is just around the corner. But today, when we're in the heat of this pandemic, 2022 feels like, oh, so far away. And why did we not, at the beginning of the massive federal investment in building this technology infrastructure, do more to invest in the actual exchange of data as opposed to the adoption of technology? So some of us who were a bit involved in some of those early efforts may be kicking ourselves at this point. I know I am a little bit. But having said all of that, we need to sort of, first of all, we need to build on what we have. We're not going to build, an infrastructure overnight. So we need to leverage what's out there already. One example of this would be health information exchanges. These are, essentially sort of information sharing vehicles, collaboratives, infrastructure that exists in most states, and many of them are also linked nationally and increasingly linked nationally in order to share data for treatment purposes. And being able to flip that switch on to enable the public health sharing, I think is something that a lot of HIEs are working on. They start with these policies that only allow them to share for treatment. So they've got to basically get everyone to agree that they're now going to share for public health. And they have to make sure that the legal pathways for them to do so are clear to them, which I think the federal government has helped a lot with some guidance that they've put out in that regard. But it's still, I almost feel like, to the extent that there's still hesitation out there and that these systems aren't working in the fast way that we need them to, even the ones that exist today, again, and are sharing data robustly and responsibly and responsively for treatment purposes, like, why not for public health? Is it public health isn't ready to catch that data that's coming through these pipes? Like, what are some of the things that we can do in the near term while we're waiting for this more scalable infrastructure that is coming?
Thanks, Devin. And Ravi, I wanted to turn to you. One of the questioners was asking specifically about claims data, and clearly as a payer, you've got vast stores of claims data, and as well, you've been doing a lot of thinking on some of the technical aspects, both in terms of the clinical data, but also some of the social determinants of health data, which, as KP mentioned, are incredibly important as we're thinking about outcomes from COVID. So curious on your reflections on, what are those tech issues that are that we're facing right now, and then, are there solutions like, say, in standardization or in terms of trying to reconcile the claims data that could be useful?
Absolutely. Before I get there, I just want to follow up to what Devin was saying. Her point on using the health information exchange data was spot on. Independence Blue Cross, as I said in my opening comments, we were able to take use of that data. That is real-time data. The minute a person gets admitted, discharged, transfer, we were getting pinged on our end. The claims data has a lag. They have a lag of about a month and a half. We cannot wait to make decisions with claims data. That is all, the claims data are all around, how can a bill get paid from a provider's perspective? It might not have all the coding, the social determinants of health with what KP was saying. Also, I think that the adoption of social determinants of health when it comes down to providers, we need to do some kind of an education so that more and more providers are using it. I know the American Medical Association, they added certain Z codes in order to do, social determinants of health. That needs to be captured. Race and ethnicity, I totally understand the privacy issues that Devin was talking about, but you need to get to that granular level of data when you are collecting in order to do outreach programs. KP mentioned, rightfully so, the things that you were just asking me, Rob, around, what are the technology challenges? One of the components, people are spending vast amount of money on big data, right? You are collecting data, to KP's point, we did research around, who are the members who are getting COVID. And if we broke out our data into essential versus non-essential customers. And we saw that spike of COVID cases with essential workers, only because we had that industry code in our data sets. We had, data around, where are the parks, what are the grocery stores availability in a certain zip code or not. And, we are able to do, predictive models, big data models around that. But that implicit bias that KP mentioned was spot on. Unless and until you do not have data in the training data sets, that bias will reflect in the outreach. So, as a payer, we make extra precautions in terms of testing out for the bias, making sure that that bias doesn't carry forward, within our algorithms. But, that is a challenge for, on the provider end. They do not have longitudinal data. They do not have access to the 360-degree view of the member. So, for them, I do believe that, they need to come up with better pipelines and work with the payers, work with the government in order to make sure that they get the 360-degree view of that member. A member might just go to an ER one day, and the doctor might just know that particular instant. He might not know that he had 10 other conditions. He might have been, he might be a victim of abuse in the past. So all of that information are all critical in decision makings. And I think that we owe it to ourselves to make the privacy laws adapt to these data exchanges, so that we all can take advantage of some of these solutions.
Great, thanks, Ravi. And KP, following up on Ravi's points, there were several aspects here that I'd love your reflections on. One of the technical issues here is that, frankly, we have really messy data around race and ethnicity, and also around a lot of the social determinants on health. As an outsider, you may think that we should have this great data that we can just turn to and mine and think about. In reality, it's poorly collected, if collected at all, and frankly, it's messy when we do have it. So, curious, from your perspective, are there ways that we could improve that? What is the current situation technically that is keeping us from making the progress we'd like to?
Right. So I think this gets to the sources of data that we're aggregating and where they're coming from. So, if someone comes to the hospital and is sick, and then we collect the data, it's after the fact. They're already sick. And in some cases, they're dying. An African or Black American person in Atlanta goes to the ER, severely progressed COVID. We collect the data then and they die. So it's after the fact. So the issue is, what data sources would help us better predict and prevent that from happening? And that those data sources aren't sitting in our traditional data sources we're aggregating now. So there's the provider data, there's the claims data. When we think about this SDOH data, right now the framework is to think about the service provider or the payer collecting that data. But if you think about the point in time when that data is getting collected, is when someone's come into the health system, they're already sick or they're already dying. So to my point earlier, I really believe that this is about, particularly with the issue of trust, it's about community organizations. Community organizations are in the front lines of these communities doing the work. They're there interacting with the communities. They're there offering services. They have the trust of the population. And actually, I believe that a lot of what we need in the COVID context to get to these issues is sitting in those pools of data. In some cases, they may be collected better than others. So I think it's not as much as saying we're just going to census data, American community household data, labor statistics. All of that is kind of like telling us the story of what is happening, but not allowing us to intervene. And so I think that, when we think about social determinants of health, the anchor of that are non-healthcare institutions that are doing that work. And what data are they collecting? And then how does that data get aggregated and layered into the great work that people like Ravi and Ken are doing, so that they can then build those predictive models that the outreach team, so now the groups that do the work of the prevention, can use to do the outreach beforehand, so that we get people intervening in a true public health and preventative model. And so it's, I think, as a country, we're working through health information exchange, we're working through collecting broader data sets, but the point of time and the sources are, I think, where the real issue is.
Thanks, KP. And just to circle back through the questions that folks asked, one of the questions was really about understanding the standardization of the data, and we've talked about that in a variety of aspects here. Ken, I'd love to turn to you to talk through some of the challenges in standardizing data that we do have now, and the general lack of success that we've had to date to be able to marshal that data for timely decision-making by policymakers, researchers, public health officials in the before times and especially during the COVID-19 epidemic.
Yeah, so, there's no question that we have not been extremely successful to date in using standardized data. The 21st Century Cures Act and the two rules absolutely standardized something called the US Core Dataset for Interoperability, which we have the opportunity to grow over time, but that right now is the data set that will be universally available. So Ravi should and team at the private payers are looking closely, I'm sure, at what CMS is doing with claims data, making those available in the same format and across the same APIs. So CMS is doing this at scale with very innovative programs. And interestingly, while Ravi's point is well taken, that those are not great data for daily responsiveness to public health epidemics, there's a lot more to public health than just the infectious disease acute response. And those data do have tremendous value, as he mentioned, and as we mentioned in this 360 view of the patient. And those are coming out in the same format. So now we have standardized data from payers, and some private payers are following along with this. And then KP's points could not be more spot on. The social determinants are very hard to extract from health system data because of a variety of things. One thing we can do within the health system data is to find them in the notes. Social worker notes and other things have these things, and there are computerized ways to get those data out of the notes, and the notes are becoming part of our standardized data sets. But also, I really like KP's ideas about leveraging new information sources and beginning to standardize the ways we collect those. And those can be from community organizations, which clearly through referrals and payment process also are collecting these data, and there should be insight into those. And also the patients and citizens themselves through these APIs, for example, through the Apple Health app, we do have the opportunity for participatory surveillance where patients can actually voluntarily contribute data. And there are some very interesting examples over the last number of years where we're able to actually leverage hundreds of thousands or even millions of patients willing to contribute data through apps models and other models. So this, and because of the standardization, we have a lingua franca to store and exchange these data now. So we don't want to in any way stop with the health system data that has all the caveats that KP and others began to address. But I think it's a very good start, and then we need to complement it. And also the US core data set could be expanded to require critical social determinants. What I see is that these regulations really make a difference in the data that become available and the architectures that are available, we have to use those data.
Can
Thanks,
I say
Jen.
something? Sorry, I didn't mean to interrupt.
No, please go.
Okay, I just wanted to chime in on, this social determinants data and sort of collecting more of it, having more of it being part of a clinical record, having more of it being part of public health, collection of data for public health response is again, one of those issues where painted with a very positive brush. We can use it to help see what interventions work. We can use it to understand this pandemic much better. There are many aspects of this pandemic, not just the clinical ones, and I think this pandemic in particular, where social determinants are extraordinarily useful. On the other hand, it is the very type of data that raises a lot of sensitivity with people in terms of who has it and what are you doing with it. And so the absence of sort of any safeguards that people can depend on in terms of how this data is being used and how it won't be used to penalize people, to throw them out of the country, to discriminate against them in employment or health insurance or other types of insurance that they may be trying to get, is really going to be critical. If you want this data coming in from everybody, you've got to decide, I think, that you're just not going to allow it to be used for certain purposes that will create trust barriers.
And Robbie, it looks like you may want to jump in on this point as well.
Yes, absolutely. And I couldn't agree more with Devin and Ken. Ken, to your point, you mentioned provider notes. That is something that, as we get EMR data, as we also collect, customer call data, we are using technology. The insurance companies are using technology like natural language processing in order to find those nuggets so that they can make them a part of their predictive models. And it has just become more and more important that you collect any kind of data that you get in these decision making. And these, and I to Devin's point, I think that it should be limited to only medical management decisions. Beyond that, these data should not be allowed for any other kind of outreach, whether it is to make decisions on life insurance or health insurance claims. As long as we can put it, keep it within the medical management space, I do think that these data, the granularity of this data will go a long, long way.
Thanks, Robbie. KP, it sounds like you want to jump in here too.
Yeah, so there's something we're working on that's I think relevant to this and shows some of the complexity. So right now we're working on an initiative with Emory Healthcare System in Atlanta on COVID response specifically for communities of color and how to mobilize communities of color around testing. Now the model for that, based on many of the themes here, is one, using data to understand the nature of the problem in the communities, and then how to do outreach digitally and otherwise to get people in a more preemptive way. And to Devin's point, I think you just hit the nail on the head. I think to get this done, it's really at the intersection of the policy and the community organization. So some of what we've had to do in this initiative is, while Emory is one of our partners, they have data sources and things they know about the community. So does the community organization. So what we're going out and doing is talking to the community organizations and setting separate agreements with them, navigating TCPA, HIPAA, and all of that then enable us to go down into that specific patient population of that community organization. So while on the surface it sounds straightforward, even the regulatory matrix of agreements straddling privacy and tech issues, TCPA, HIPAA, to just be able to reach into a community organization and its population and use that trust to mobilize the community becomes some of what practically has to be done. And so I think, because at the end of the day, let's not forget, this isn't data for the sake of data. This is data and insight that really is to prevent morbidity and mortality. And so it has to somehow connect the data and the insight to the delivery of service and the preemption of COVID growth, the growth of COVID in these communities. So, I think, it's, we're navigating that with Emory and with the community organizations, but the way we've done it, to Devin's point, is for every community organization, there's intentionality. Why do we want to engage with you? How do we intend to mitigate COVID for your people? What is required to do it? What data do we need and why? How is this benefiting your population? You need to answer all those questions. And if you make a good case, the community organization will engage. And through that trust, their people will engage. But it requires that work. So, I think a lot of good comments have been made, but that's something we're working on in Georgia, where, as all of you know, it's a very complex environment.
That's helpful. Well, I know we're approaching the end of our time together, so I want to have one last question for each of the panelists, and everybody gets a minute or so to respond. But if you did have a magic wand to deal with the challenges that we've got today, what one solution would you put in place, either at a private payer level, private health care delivery level, state, federal? Where would you go and what would you do? So I'm going to do reverse order from how we started this. Start with Devin then. What would you do with your magic wand?
It is going to have to be a really powerful magic wand, because I'm going to say how great it would be if we had a comprehensive privacy law in this country with strong protections against harms and also controls around data, so that we wouldn't have these questions keep arising. Well, what's going to happen to my data if I share it? We could actually have a response to people that was a decent one and not one that had 1,000 caveats. Well, maybe.
It's a very powerful magic wand. KP, what would you do?
I might cheat a little bit and say, Devin, her magic wand, that happened, so that's in place. So I'm going to build on that and say that happened. So I'm cheating a little, but that happened. And then I want to see, kind of to Ken's point, this SDOH data move into some type of nationalized framework from non-traditional sources, maybe through CORE or something of that nature. So I think that's at the heart of prevention and mitigation.
Great. Thanks, KP. Ravi, what would you do?
I think the partnerships between payer, provider, and the state officials, I think is key. I know that they have already started going down that path with some of the interoperability stuff that Kenneth was talking about. But I do think that once those are things that are in place, they need to scale, make it mandatory, and then have at it. In terms of what we can do for the community. I think it is essential, and I think with this pandemic, I do feel that it is a catalyst. I think Devin mentioned around telehealth. It is a catalyst for starting these dialogues, as well as hoping that we all come together as a community in order to fight this.
Thanks, Ravi. And Ken, you're going to have the last word. So where would you deploy your magic wand? It sounds like you've already deployed it a little bit with 21st Century Cures, but are there more things that you want to see happen?
Well, after the $48 billion federal investment and in the midst of an unprecedented public health crisis, I can't think of a more opportune moment for Congress to leverage the combined and synergistic expertise of the Office of the National Coordinator of Health Information Technology and the Centers for Disease Control to work on modernizing public health infrastructure. And public health needs intelligence and situational awareness based on what's happening in the healthcare system, and that capability is within reach at scale.
Right. Well, unfortunately, we are out of time, but Ken, Ravi, KP, Devin, thank you so much for joining with me today. And I'd like to remind the audience to tune back into this page at 2 o'clock for a conversation about the NIH's National COVID Cohort Collaborative. That's going to be discussing the innovative research approach to advance our understanding and treatment of COVID. And with that, thanks so much, and hope all are staying well and staying safe.